Thank you for joining us. The following presentation is from a webinar titled Direct to Employer, Dealing with Narrow Networks in the New Exchange World, and was originally produced on September 25th, 2014. The presenters were Suzanne Sentman, McKonly Asbury's Human Resources Director, and Ernie Sulis, a partner and attorney at Rhodes & Sinan LLP. Enjoy the presentation and visit us online at www.macpas.com for information about our future events and upcoming webinars.
Thank you, Tyler. As Tyler mentioned, my name is Suzanne Sentman, Human Resources Director for McKonly Asbury. One of the things that we strive to do is to provide our clients with timely information regarding a variety of issues. Healthcare reform is one of those very large issues out there that many folks and employers are constantly watching. Today we're going to take a deeper dive into healthcare reform and the various models out there, but specifically narrow networks. With me today is Ernie Sulis. Ernie is a partner at Rhodes & Sinan, and he is our subject matter expert for today. So welcome, Ernie. But first, let me tell you a little bit about him. Mr. Sulis has practiced exclusively in the health law field since 1980. He has specialized and lectured in the areas of hospital-physician integration strategies, ambulatory surgery, center development, compliance plan development, e-health issues for providers and payers, global risk and managed care contracting, fraud and abuse and STARK II law issues, hospital-based physician contracts, reimbursement, and medical staff matters. Mr. Sulis has been featured as a speaker at numerous conferences. Mr. Sulis focuses his practice in the areas of clinical integration and ACOs, hospital-physician integration transactions, ambulatory surgery centers, compliance, group practice and professional practice entities, hospital-based physician arrangements, hospitals, medical practice transactions, and medical reimbursement. That is quite a list. I think I covered it all. So please join me in welcoming Ernie.
Thanks, Suzanne. Good afternoon, everyone. I just want to emphasize from that introduction that I am a healthcare lawyer, and most of my career has been spent working with providers and payers. But with the emergence of healthcare reform, the relationship between those two categories of clients and employers and employees is really unbreakable at this point, in my opinion. And I wanted to pick a topic that, although tied to healthcare reform, really kind of focuses on a model that hits all major stakeholders: providers, payers, employers, and employees and patients. On the next slide, you'll see what I intend to cover this afternoon. I want to talk briefly about what is driving change in healthcare, then describe some new business models that are emerging for healthcare providers, plans, and employers that are relevant to this topic. Then we'll dive into, what is a narrow network and what are direct-to-employer type relationships. Take a quick look at current adoption of narrow networks and private exchanges as opposed to the ACA public exchanges, and then some legal and regulatory issues that are developing in various states because of this structure. So what is driving change in healthcare? I'm sure most of you have a good sense of a lot of things that are doing that, but I think the point to emphasize first is that everyone thinks that the ACA, Affordable Care Act, or Obamacare are the reason we're in the place we are today. And in my opinion, it really is driven first and foremost by the two issues of cost and quality in healthcare. It's amazing to me that as advanced as we are in terms of a healthcare system throughout the country, we are as a country first in the highest healthcare costs and last in quality performance among industrialized countries. I think that kind of says it all, that our healthcare system needs some work, and these models are designed to achieve the goals of fixing that problem. We all know about the Affordable Care Act, and just emphasize that point that it really got the ball rolling in many respects, but that ball is rolling out of control now, and the government, whether or not it's repealed or not, is not going to change that one bit, in my opinion. We're seeing consolidation at all levels of the healthcare arena. Hospitals are consolidating into bigger systems. Physicians are consolidating into employed relationships with hospitals. Health plans are consolidating and employers are consolidating. I mean, if you think about hospitals, for example, in the Philadelphia marketplace, 5 years ago we had about 30 plus systems, health systems in the market. Now we have about 7 that are independent, not affiliated strongly with another system. Physicians, the majority of physicians in America right now are employed by hospitals for the most part. You look at health plans, there's probably 4 big categories in the country: Blue Cross, Aetna, Cigna, and United Health. And employers, you all know about the consolidation going on there that's going to drive higher levels of self-insurance and higher levels of direct-to-employer relationships. Legal issues are fraught around that whole consolidation, which we won't spend time on today, but the antitrust regulators are looking at all of these various forms of consolidation in healthcare and defining some pretty stringent rules that you have to comply with. We may have all heard about the sort of move to consumer-driven or retail healthcare and high-deductible plans. Now that consumers, patients, employees are responsible for their own care and the cost of that care, they're shopping in that retail manner, if you will. There are what I call disruptive models. So it's not just about those 4 major stakeholders I described. It's really about entities becoming sort of healthcare enterprises. So you see Walmart and Walgreens and CVS all providing care in their locations through either their own physician extenders or through relationships with area providers. You see venture capital coming into the arena with venture capitalists putting a lot of money, for example, into networks that are designed to just serve the Medicaid population, where the biggest opportunity for reducing cost exists, and which is breaking the bank for most states in the country. You see price and performance transparency, so scorecards and public listings, if you will, of how physicians are doing in both quality and cost performance. I mean, and this disruption just continues. I was working with an academic medical center client talking about the shortage of primary care physicians, and he told me that the way they're handling it is as follows, and he pulled out his iPhone, and they went out and they bought a technology company with an app that basically becomes the interface for a patient visit as opposed to seeing a physician. So those innovation-type initiatives are rampant. Public and private exchanges are developing. The public exchanges through the ACA and the private exchanges developed by consortiums of employers and the large human resource consulting firms, and we're going to talk about the private part of that more later. And all of these are resulting in what we call payment and delivery system changes in the market, and we're going to talk in detail about that as well. So with all this swirling around, what kind of new delivery and payment models are emerging for healthcare providers, plans, and employers? If you look at the next slide, I've listed some there and want to briefly describe each one, give you some examples. I'm going to try to use examples in the market throughout here because I think it's hard to take general principles and acronyms and apply them to any meaningful way, but most of this stuff is already happening in the marketplace. So clinically integrated provider networks and ACOs, or accountable care organizations, same sort of bucket. And these are generally entities, legal entities, separately formed legal entities that are owned by hospitals or physicians and/or physicians that represent hospitals, physicians, and other providers in the spectrum of the healthcare continuum. Meaning post-acute providers, home health, and those sorts. Provider health plans, so a couple examples of a clinically integrated network ACO, and these come in all shapes and sizes, and I want to give you a sense of that. So there's a company I work with that is a network of about 250 primary care physicians, no hospitals involved whatsoever, that have organized themselves in a way we're going to talk about a little later into a clinically integrated network and have all the capabilities that we're going to talk about later. But they did this all on their own dime, essentially, to start. And then they entered into a contract with a major Blue Cross plan, and had that contract for 5 years. And during that time, under a shared savings model, meaning the savings generated, the reduction in cost generated for the members of the Blue Cross plan that were managed by this particular organization generated $82 million in savings, cost savings. Again, this is without sophisticated IT solutions. They developed their own population management tools. So you see a physician-only organization can do this. We have another organization, a very small, 200-bed or less community hospital in a rural area that on May of last year didn't know what an ACO stood for, and by July they were the first to file an application to be admitted to the Medicare Shared Savings Program, the ACO program, and accepted. And they are moving forward with, in a pretty successful way, gathering physicians together, developing quality metrics. So you can see how they can do it at small community hospitals and small aggregations of physicians. Working with an academic medical center that is composed of 1,000 physician faculty practice plan, all employed, affiliated independent providers, ACOs from other organizations, and brought that all together to develop a multi-state clinically integrated provider network. And then we have one in which the Blue Cross plan themselves developed their own clinically integrated provider network, and that entity essentially contracts back with the plan on a risk basis. So you can see that these sorts of organizations and entities will arise in all sorts of settings and situations. Really, it's the innovation aspect of this that is really working in the marketplace. We see TPA functionality changing, and by that I mean third-party administrators, as you may know. The sort of traditional legacy health plan, if you will, would be the combination of a network as well as these third-party administrative functions of claims processing, disease management, wellness programs, etc. Many of those are being taken over by providers, large health systems, provider networks, and they're combining the network with the TPA functionality to create these direct-to-employer types relationships. I think you all probably all know about employer consolidation. We'll look at that a little bit later. And the key here is not only the structure of the delivery system, but rather the change in the way healthcare is paid for in this country. So what we talk about is historically we have used a pay-for-value payment methodology, meaning you got paid for the more episodes of care you delivered, whether it's an office visit, a surgery, etc., a hospital admission, hospital readmission in some cases. And now as that has changed to pay for performance, where you're paid based upon quality outcomes and cost efficiencies in terms of savings. But what I call this is, sort of follow the money. As we change how healthcare is paid for, that will determine how healthcare is delivered, in my opinion. So these sorts of models include things like quality incentive programs where physicians have to achieve certain levels of quality outcomes, certain levels of clinical performance, patient-centered medical home in which their physicians are asked to coordinate care of their office patients and get them to the right place at the right time to keep costs down. Shared savings models, which say that we'll set a payer or the government will set a benchmark for historical cost performance of a population, Medicare beneficiaries, for example. And then the contracting network, the ACO, works on the type of redesign of care delivery that drives savings off of that benchmark or not. But then the government shares 50%, depending on the model, with the network for achieving that shared savings. There are bundled payments, which are really risk-based payments that are more related to episodic care. So surgeries, knee replacements, all those sorts of things that are more inpatient-oriented. And a target is set by the payer or the government that you should perform this particular type of episode, this particular type of procedure within this budget. And if the cost you incur to deliver on that episode is below that, you get to keep the difference as a provider. And then there's risk and global capitation. This is not a predominant model yet on the East Coast. It is the way of life on the West Coast and some other parts of the country, Minnesota in particular, Wisconsin. But that's where someone gives you what we call global capitation payment and says you're responsible for the total cost of care, whether you deliver the care or not, to a defined population of individuals. And you have to operate within that budget or you're basically at risk for the loss, and that comes out of your pocket.
Ernie, I have a question for you, if you
Sure.
don't mind. When you were talking about the clinically integrated provider networks and then those TPA functions, it almost sounds to me that these groups, these physician groups, are taking on the role more so of the, I guess, traditional insurance carrier.
Very, very, very close to it. What we're seeing is an evolution in the market, and these are many of the models I just described are for most physicians upside only. So if the savings is generated, then they get the share in that, but the plan really keeps the rest of the savings. So they aren't taking what's called insurance risk and therefore not regulated as an insurance company. But that is exactly the point of this discussion today, is that they become essentially an insurer, even if they're not a licensed insurer, with direct-to-employer type relationships, which are protected under ERISA from state insurance laws.
Interesting. Thanks for clarifying that.
No problem. So briefly, just kind of touch on some things on the next slide that kind of define what a clinically integrated organization is. And really, it has three main goals in the market. And this is what we call the triple aim, a nomenclature developed by Dr. Burke, Dr. Donald Burke, who came up with this approach, that we want to improve the patient care experience. By that we mean improve communication with patients and caregivers, team-oriented care, where it's not just the physician who renders the care, it's the entire spectrum, and they work as a team as opposed to individually, where the patient has accountability for their own care. And in many cases, how happy a patient and their family is will determine payment in the future, because patient satisfaction scores are key to many of these payment models. You're also trying to reduce the per capita cost of care, as well as improve the health of the population defined by measurable outcomes of clinical performance. So you see this as an organization consisting of, as I said before, physicians and hospitals usually are the starting place, but it can include any kind of healthcare provider. It is also becoming a physician alignment model for hospitals, in which rather than employing physicians, which has been the traditional model, they can have a close relationship that is long-term and sustainable because of the nature of the care of the model with independent physicians. So independent physicians can keep clinical practices but work in this model with hospitals. And it strives to eliminate health disparities among defined populations. So if you think about the fact that in a population, so you're not managing patients necessarily, you're managing a population of individuals. There are going to be healthy individuals. There are going to be at-risk individuals, folks who don't yet have a chronic disease but are heavy smokers or obese, and are moving in that direction. And you have those with chronic disease like coronary artery failure, coronary heart failure, diabetes, and similar types of chronic diseases. So it requires something that kind of works across that spectrum. This is just the visual to kind of emphasize what we're saying here, and the fact that providers are now paid for efficient and effective outcomes rather than paid for volume, and that's a big issue today in these relationships, because if you think of it, hospitals and physicians are still being paid fee for service, so they have this sort of conflicting goal, if you will, of reducing cost and controlling volumes, and yet that's how they're paid. So there is some level of transition there that needs to be accomplished. Most of these networks are continuing their existing payment arrangements on a fee-for-service basis under their own individual plans, individual health plan relationships and contracts, while getting together and entering into the volume-based types of arrangements of ACOs that we just described, and generating value-based payments for that. So you're getting both while not kind of standing still. there's something called, demand destruction here. So they're being paid under these models to keep people out of the hospital or to keep people out of their office. So that is something that needs to be accounted for when they look at the finances of these sorts of relationships. On the next slide, just want to mention briefly the sort of things that support the provider structure, if you will, that are keys to success. First and foremost, data integration. I mean, combining patient data from disparate sources is so critical to the success of an ACO or any other clinically integrated provider network. How that data gets built into a common warehouse, how it is accessed by individual EMRs, electronic medical records of providers and hospitals, how those EMRs feed back in and produce reports so that there is a constant loop. How do they get claims data from the payers they deal with? All that has to be integrated in some fashion and then delivered essentially to the point of care in a meaningful way so that the physician extender or the physician in their office, when Mrs. Jones comes to visit, he or she can kind of use that data meaningfully. It's not just a nice report. It actually can say, Mrs. Jones missed her appointment last week, her rehab appointment. Why was that? A caregiver reaches out, which goes to the next point of care coordination. A caregiver reaches out, a care coordinator or navigator reaches out and says, why weren't you able to make it? Transportation issue. The care coordinator now has to kind of help solve that problem for Mrs. Jones. So you can see how these all kind of build on one another. Risk stratification tools, meaning predictive modeling. So you can see an episode coming for an individual patient based upon these sorts of IT solutions. And that's so critical because you can target the interventions at the right place at the right time. And many times, there isn't like a static population of chronic disease individuals. Some you'll find are high-cost individuals in one year, but in the next year they're low-cost individuals. Even though they still have the disease, they're managing better. But you have targeted your interventions in all these ways at the high-cost individual, not realizing that they're now low-cost and we should be targeting the high cost for that particular period. So it's really a very complex and elaborate structure that supports the actual rendition of care. And then patient outreach. Most organizations that are pretty well advanced have patient portals, so patients can actually see what their care their care outcome, can see their lab test results, can email the physician's office and all those sorts of things. And really engaging patients in their own care is key to success in these models. You've got to deal with barriers like language, transportation, socioeconomic factors. It's very much changing the world one patient at a time. So that is sort of background of sort of what the market looks like in terms of healthcare payment and delivery. Feeds into these concepts of narrow network and direct-to-employer relationships. Narrow networks are not necessarily a new term, but how they've evolved in the current market is really what we want to focus on. So, going back to the HMO days of the early 90s, the term narrow network was used quite often, but that was developed mainly by who the health plan could get to accept in the provider community to accept reduced rates in exchange for directed volume. So we can send you, more of our members if you give us this rate, which is well below the rates of others. And so those that were willing to agree to that constituted the narrow network, kept premiums down, made profits for the health plans, and drove volume for the providers. So, but it didn't impact quality at all. It didn't even look at that aspect for the most part. Moving forward today, we see multiple applications of the term narrow network, and when using that just as a sort of a placeholder, they're called other things in different places. They're getting branded by organizations with a fancy name. But you see them in DTE, direct-to-employer relationships by a provider health system that has a clinically integrated network. You see them developed by insurance companies who have put one or more insurance products on the healthcare exchanges. You see it in an insurance company who really serves a TPA function for a self-insured employer. So kind of distinguishing direct to employer by a provider, and then the insurance company is sort of the intermediary that has contracts with providers for the network, but delivers that as the front face, if you will, to the employer. So a common definition of the aspects that you see in a narrow network are sort of high-performance provider networks that are focused on quality. This is, again, today's world, not the original concept, with substantially lower premiums. And they accomplish that by restricting network participation to those most effective and efficient providers, as well as, of course, by different types of plan designs in terms of deductibles, co-pays, and those sorts of things. You'll see in these sorts of relationships more and more performance-based contracts that we talked about, bundled payments, episode payments, shared risk and savings, capitated budgets, that oftentimes drive prices, substantially below standard PPO fee-for-service rates. According to most plan sponsors that you talk to today, current narrow networks are focused on quality and cost metrics, not simply price or fee-for-service rates. And they're akin to the HMO networks, as I said, but now quality matters and not just cost. So quality has become the sort of gating factor to receiving these sorts of value-based payments by providers. So when we think about narrow networks, we also sort of continuing from that last slide, are focusing what we call on value. That's the new term, value-based purchasing and value. And it's the combination of reduction in costs, quality performance, patient satisfaction, wellness and well-being, use of care transitions, and addressing socioeconomic factors. You see it in DTEs. You see it in a narrow network can be simply a form for a DTE, direct-to-employer relationship. It could be formed as an ACO, commercial or Medicare ACO, and it could plug into an insurer relationship for a type of exchange. And so when you talk about narrow networks, you've seen a lot of these entities form for other purposes, serving that role when it comes to the employer relationships. And lastly, it's important to keep in mind that the geographic market or sub-market characteristics are going to drive size, structure, focus of what a narrow network looks like. If you're in a payer-dominant market, it looks one way. If your area has a certain demographic characteristic of its population, the needs of employers, they're all going to vary in geography and market. So there's not one size fits all in these sorts of relationships. The sort of going hand in hand with the narrow network concept is direct to employer. So a direct to employer relationship is one where an organized provider network, like we discussed, a clinically integrated or ACO network, contracts directly with a self-insured employer to deliver care to all of the employer's employees, rather than the employer contracting with a large health plan to serve as the TPA and network. Doesn't mean that a health plan as TPA doesn't also offer a narrow network product. That could likely be the case. And we always have to remember that sort of employer plan design is going to influence the impact of the network. So we could deliver the best care in the world, but if there isn't tied to some sort of individual employee patient incentive program, it may not work or deliver the outcomes you're looking for. And as I said, I think previously, the term narrow network has developed a bit of a negative meaning in the market among employees and employers because it has this inference that there is a lack of choice and something is being shoved down the employees' throats. And that is not at all the case. So you're seeing new branding, use of terms like select network or similar types of terminology. I think, as I said, those are great, general concepts, but it's always important to look at what are some examples of narrow networks. And so there's plenty of them. I've picked out 3 that have sort of different characteristics, if you will. Organization known as Banner Health. Some of you may know of it. It's out in the West and Southwest, 24 hospitals in 6 states, and it brings together a network of 24 hospitals plus thousands of physicians that is taking their model directly to employers. So they don't necessarily aren't developing a health plan. They're not operating as a health plan, but they're delivering care to the employees, getting a payment for that, whether it's shared savings or quality-based, as well as negotiated fee-for-service rates to deliver a narrow network to all of their clients. And they have a number of them. Another example is Cleveland Clinic in Ohio, and obviously nationally recognized. And I put this in here. Differs from Banner Health in the sense of it's really broad national focus, particularly in heart and orthopedic care. So they sort of first established the model where employers, and these are again DTE relationships, where employers would contract with the Cleveland Clinic based upon the excellence of their cardiovascular and heart program on a risk basis, essentially a bundled payment for defined procedures. And because of the not only the quality outcomes of the Cleveland Clinic and its affiliated groups, but also the way it was delivering care in a very cost-effective manner, it actually became cheaper for employers to fly employees across the country to receive their care at the Cleveland Clinic than it was to put them into the local healthcare system and have them go through 3 or 4 readmissions and unnecessary ancillary service tests because there's no management of the care in that locale. They've also developed that model in orthopedic care. So they've contracted with 3 major what we call orthopedic supergroups: Rothman Institute in Philadelphia, Ortho Carolina in North Carolina, and I believe it's Core Orthopedics out in the Southwest, to basically deliver all of the total knees, total hip procedures for their contracted employer groups like Lowe's and Walmart and other similarly sized employers. So you see that as an emerging model as well. The other model I want to show you is something involving Aurora Health, which is a provider health system, and Anthem Blue Cross in Wisconsin. Again, this is an example of a provider-payer partnership that is taking a product called Blue Priority to the employer market. Consists of Aurora Health has a very, very excellent clinical reputation, 1,500 physicians, sees 1.2 million patients each year, consists of 15 hospitals, 160 ambulatory clinics, and is essentially creating a new health plan product. So when Anthem goes to an employer to sell the product, Aurora Health is at the table with them. And just this week, there was another one that I didn't put in the slides that was announced, in which Anthem Blue Cross of California, Southern California, created a product known as Vivity, by a partnership with 7 Southern California health systems. So the big names, Cedars-Sinai, UCLA, et cetera, have all come together with Anthem and actually created a new licensed health plan in that market, trying to steal some market share from Kaiser Permanente, which is sort of the well-known integrated model of both care and health plan function. So this is trying to pull some of that market away from the Kaiser organization in California. So every day you probably see, if you follow the healthcare trade papers, another example of someone doing something like this. On the next slide, I want to just briefly show you a sort of a different aspect of the provider-oriented narrow networks, and that's a company called Imagine Health, and they tout themselves as a builder of custom high-performance teams of the highest quality providers for employers with large concentrations of employees in a single geographic area. So they say they are not the network, so they're sort of a broker of a narrow network, if you would, and they bring to the table the agreement of a provider network that has undisputed quality and cost scores, if you will, working with Fortune 500 employers and markets across the country. They'll provide some assistance with plan design, but they do not provide TPA functions such as claims processing and population health management. And they also sort of package this with their own IT solutions. So they have apps, social media solutions that connect employees with the teams in a way that makes sure that the cost is delivered, sort of in the right place at the right time. I was representing a very large health system down in Texas, and last year they received an RFP from Imagine Health on behalf of Walmart to basically deliver the network. And we had to kind of go through a process of describing what we could do. They didn't accept that RFP. Turned out they were actually kind of focused more on the sort of old way of doing things and squeezing price concessions out of the network as opposed to focusing on quality and cost performance. But in any event, again, we have to kind of open our minds as to what these things are in the market because they no longer have a traditional look and feel. It's all about innovation, partnerships, and collaborations. So I want to talk a little bit about the concepts of how these concepts of narrow networks and private exchanges are being adopted in the market, if you will. The next slide shows. I think it's kind of an interesting take. So if you look at the first question being at the top left, it says, which type of health insurance plan would you rather have? A plan that costs less money but has more limited range of doctors and hospitals you're allowed to see, and 37% of the employee respondents said that's the type of plan that they would want. And the other option being a plan that costs more money but allows you to see a broader range of doctors and hospitals, and 51%. But then when you ask the kind of follow-up question that the Kaiser Family Foundation did in this research project, so asking that 37%, what if that meant you would not be able to visit the doctors and hospitals you usually use? Would you still prefer a plan that costs less but has a more limited range of doctors and hospitals? Or would you now prefer a plan that costs more but includes a broader range of doctors and hospitals? And you see how the numbers change. All of a sudden, 51% becomes where they wanted a broader network, and that kind of changes from 37 to 23, as you see. Same on the other side of the picture. So I think it's just illustrative of sort of the confusion in the market by employees and patients. I mean, I do this for a living, and picking health plans becomes a bit complex to me, and I think Suzanne and I were talking about that earlier, or for our parents or others in our family who may be sick. So it becomes, I think, is important to mind because the opinion of employees does matter in large employer organizations, and sort of eliminating this confusion and sort of creating the right perception of the, quote, narrow network concept is important to success of the model.
Ernie, do you think some of that maybe confusion or some of those trends are a result of the managed care situation that happened in the 90s?
I think so. I think so in large part. There's still some backlash from that. I think it's a new generation of people that are buying health insurance, but I do think that they still think of that, and that's why it changed in the 90s, is because of that backlash. And I still think that confusion
or they're listening to their parents talk about
yeah, exactly.
their experiences, right, as they help them pick out health insurance plans.
Exactly right. So again, the impact of this sort of perception on employer-employee discussions about narrow network is important. Just some sort of factual information here. I won't go through this in intimate detail, just point out a couple highlights. But this is an overview of the sort of national employer market size across the country, and to really emphasize the point that size matters, and what's driving a lot of the models for narrow networks and direct-to-employer relationships. I mean, if you look over on the left in the 2011 data, you see how you talk about concentration. So there are 37 million employees in what we'll call large employers, 5,000 or more workers, and there's only 2,000 of them. There are 4 million companies of 3 to 199 representing 45 million. So almost, not exactly, but close to the same numbers. You just see the concentration evidence there. You see over under the column for KFF 2013 data, number of employees in self-funded plans, 37 million nationally. So you see why the self-insured model will drive these sorts of DTE type relationships. And you see the circle of that 37 million, if you will, in which 59.8% are in self-funded plans. So that's out of the universe of covered employees. So you can see this concentration, self-insurance is driving all of this. These aren't sort of new facts, if you will, but sometimes it's important to see the numbers to really get it that this is going to drive the way things are done in the country from a healthcare standpoint. So let's talk briefly about the concept of private exchanges. So you've heard of the public exchanges, the ACA exchanges that people had to pick back at the beginning of the year, pursuant to the individual mandate. Well, the public exchanges are very similar, but they're run by private organizations designed for participation by employers. So we kind of define, remember, these exchanges are not insurers in and of themselves. It's really an online marketplace where people can shop, the employees can shop for insurance product, and the employer will make a defined contribution towards the insurance cost. You see various options. There's not a lot regulating these things, so you have some flexibility from that standpoint, but one option would be to allow the employee to choose from a variety of network plans. Option 2 would be allow the employee a choice of plans from several companies. Their traditional plan management, that TPA type function, if you will, is often outsourced to exchange operators, the private entities that kind of own the exchange. And these are usually the large benefit firms, Aon, Mercer, et cetera. Employers are warming up to this concept of private exchanges, but been slow to adopt in the recent past, but kind of that's changing. Some facts on this page and the next: more than 1 in 4 employers will move to a private exchange in the next 3 to 5 years. The current numbers about, I think the 2013-14 time frame was 7% of employers had their employees in private exchanges. By 2017, 1 in 5 Americans, the employees actually, not the employers, will purchase insurance from non-government run private exchanges. Aon Hewitt recently put out a report that, based on their experience in their exchange, the exchange saved more than $750 per worker and lowered the cost trend to a greater level than the non-exchange coverage. And in 2015, 3 million workers are going to be in private exchanges, which is more than triple the amount that are in the current year. You see IBM, Walgreens, Sears, Darden Restaurants, they run Capitol Grill, Red Lobster, et cetera, sent their employees to private exchanges in the past couple of years. Aon's has started private exchanges for mid-sized companies. Small employers are still sort of lagging behind in everything. They're, you follow the money, and unfortunately that's where the emphasis is, but they could end up in consortia of groupings that could essentially participate in the exchange as well. You see the major health resource consultants and benefit plan consultants launching those types of organizations. So I want to talk briefly, even though I'm a lawyer, I'll talk briefly about legal and regulatory issues that are kind of arising in response to all of what we see. So despite this move to networks designed to include providers who can best impact cost and quality, these access concerns are still an issue, like who's in the network and who isn't. And what you're seeing are challenges by providers excluded from these narrow networks. You see state regulators threatening open access requirements, but I think innovative options are developing that may, help mitigate this sort of concern. So I'm going to show you a couple quick case studies. Brown versus Anthem Blue Cross of California was a case that was just filed in August of this year, in which the insureds claimed that Blue Cross allegedly misrepresented that certain providers were participating providers in an exchange network. So this means that Anthem had multiple products on the public exchange in California. Individuals would call to ask before they were signing up, is my provider in? They apparently got either through the website description or telephone calls, got guidance that their old PPO providers were in the particular product. And they weren't clear on what product differentials there were. And so as a result, individuals chose a particular product, and then turned out their provider was out of network and had obvious financial implications. They have filed suit, and we'll see where that case goes. But sort of not being able to provide clarity to the purchasers, the consumers that are purchasing healthcare these days, can create unwarranted litigation. Another case example is Swedish Children's in Washington State. So Swedish Children, well-respected, well-known children's hospital, was excluded from the public exchanges there because of their cost. They wouldn't enter into the certain cost concessions that whoever the insurance company was that had the exchange product was willing to accept. So as a result, they filed a lawsuit involving the Washington State Insurance Department and the 4 of the 6 exchanges for lack of access. State regulators and patient advocacy groups have pressed for open access requirements. And again, remember, when we talk about open access, or another term, network adequacy, we're not talking about the same thing as any willing provider laws that arose in the 90s, where as a result of the backlash, sort of by state law, you were forced to take any provider into your network. But there are these network adequacy requirements that are being looked at a lot more strictly. They're very general requirements, very high level, and they're essentially subject to the individual state interpretation. So as a result, there isn't a lot of very specific guidance on that yet. So those are some of the legal examples of legal challenges that you're seeing arising in response to how payers and providers are developing these narrow networks. I think there is an answer, though, and I'm going to call innovation the answer, because of the technology that is developing. I want to give you a couple very quick examples. We can often have broad choice of a choice by patients and employees across a broad network, but still push them to the right place, care at the right time, and thereby keep down cost and create quality. So there's a company that I've actually met with known as Monocle Health Data, new startup, but they tout themselves as the only company that's providing unbiased healthcare provider rankings based on price, efficiency, and quality for both episodic care and chronic illnesses. So they can deliver information that would show how particular healthcare providers are performing with respect to cost performance, price efficiency, and quality outcomes. And this would apply not just to one small subset of care, but rather the broad scope of healthcare. And the way they do that is if you look on the next slide, what they say, multiple credible sources. I call it big data, claims data from all over the country to match with their software program, so that users, and the users really are both patients and providers, meaning that for example, a health system could implement the Monocle solution, and their primary care physicians in the office, before they make a referral, could use the Monocle data to determine who would be the best the best provider to refer to. Patients can also do that. So where we have consumer choice, patients would make the choice that here is the provider that is going to cost me the least and is the highest performance, and they can match them up, if you will. And that's why I said think match.com. It's essentially a computerized way of matching the patient to the provider to generate the best quality outcomes. Well, the owner gave me an example of one where he could actually match a 15-year-old female athlete with a particular type of ankle injury with the orthopedic surgeon that does nothing but treat adolescent athlete ankle injuries.
Wow.
And had performance off the chart. So that's why when I say thinkmatch.com, it's like the perfect match in healthcare. So that would allow both. You wouldn't have to have a narrow network. You would have the data for the two primary decision makers, the employee and the provider, to get to the right place and limit costs. Another example: the state of Indiana and Anthem Blue Cross entered into a relationship recently with a company called Castlight Health. And what that Castlight provides is a searchable database that enables self-insured employers and employees to kind of take control of their own healthcare costs and improve care. So they provide cost estimates and quality ratings for doctors and procedures and education on chronic conditions. So somewhat similar to the Monocle approach, maybe not the same matching capabilities. But you see where we're going with innovation in healthcare, and the information technology solutions that are being developed can many times address these sorts of legal issues that we're talking about. So just in closing, the way healthcare delivered is paid for is changing, and it's not going to return to the status quo, in my opinion. It is here to stay, whether or not Obamacare is repealed or not. So while the government may have initiated, quote, healthcare reform, the issues of direct-to-employer, narrow networks, and private exchanges will make this change permanent due to the sheer size of those markets. I mean, again, follow the money, follow where the cost problem is, and that's where the solutions will be built at the first level. And because, as I said, I'll just stretch it again, innovation, innovation, innovation. It's going to continue to evolve what these models look like and improve their performance. So with that, I don't know if we have any questions.
Thank you, Ernie. I'm going to turn it back over to Tyler at the time to provide everyone with a few bits of information regarding the webinar.
Thank you once again for joining us for this presentation, produced by McKonly Asbury, Certified Public Accountants. We hope you join us and participate in our upcoming events. You can stay up to date with news and learn about our upcoming events by visiting us at www.macpas.com. Thanks again and have a great day.